So now we're taking the appliance that we fabricated at step 5 and continuing the titration of the mandible forward until we either reach a point where the patient's symptoms go away or they simply can't go any further and they fail step 6. At this point, there's some additional paperwork you need to do. The first thing that I've created for you is a titration protocol. It basically tells the patient how many turns to make and how often to do it. They sometimes get confused if we simply describe it to them. So fill out the form in front of them. What are my suggestions? I usually suggest in men that we can titrate 2 turns towards their left shoulder every 2 days. In women, I tend to wait a little longer each time I titrate them. What they found in the literature is if you move too quickly on women, you can elicit discomfort, and the minute you do that, they tend to not want to continue with this therapy. So slow down on that particular type of patient, your UARS type of patient. Other forms that you'll have available through your doctor are patients that are not compliant with recall. You see, with the step 6 appliance, we're actually moving the jaw farther than normal and taking a much greater chance of altering their bite. If these patients don't come back to see you, won't answer calls, I would urge you to actually send them a letter documenting that you're attempting to get them back in. The next is a form for patients that are not your dental patient of record. If you end up creating a step 6 appliance for them, the odds of altering the bite are quite high. So you want to send a letter to their treating dentist telling them what you've done and reminding them to monitor this on recall and make you aware as soon as they see any occlusal changes. So we've walked through the first 5 steps of the protocol with the patient. They still haven't gotten a good night's sleep, started to feel refreshed, had any improvement in quality of life. So now we move to step 6. In step 6, what we're going to do is titrate the lower jaw forward until we either start breathing better, sleeping better, or the patient says, I've moved as far as I can and I just don't think this is going to work. Remember, in any trial, failure is a result. So you don't have to feel bad. What you tell the patient is, I'm glad we figured out in a provisional manner rather than making the huge investment in the final night guard that would have been required to be made at step 6. The difference is that we've now protruded 3 millimeters at step 5. We're going to continue the protrusion as we go through step 6. So we set a protocol with the patient. Let's say it's, I want you to make 2 turns on Monday, Wednesday, Friday, Sunday. And so every 2 days she's making 2 turns of the appliance. Maybe your protocol is making 2 turns only twice a week. Only you know the patient and how they're going to react. I wouldn't go much past 2 turns at any one moment, because remember, 1 millimeter of changes is a pretty big change for a patient's jaw to adapt to. I want to make a small change, see if they're sleeping better. If not, then we add to it. The key here is actually telling the patient or giving the patient control over the protrusion. The way I do that is I give them a protocol of how many turns and how often to do it, but I remind them, if you turn the appliance towards your left shoulder, you're going to be making the airway better by moving your jaw forward. If, however, that's bothersome to the jaw, you want to turn it towards your right shoulder. And I actually tap on the patient as a reminder as we go. I say, this is making your airway better. This is making your jaw better. Airway, jaw. So when they turn towards the left shoulder, they're making their airway better. If that's bothersome, we remind them, turn it back to the right shoulder to make the jaw feel better. If the jaw ever becomes uncomfortable during this process, they are to call us immediately, and we aid them in making it feel more comfortable. Once again, in step 6 of the protocol, it's important to continue nasal breathing. And so we're going to remind the patient that the obturator is an important ingredient in making sure that she continues the progress that she's made throughout the other steps. There are going to be two reactions to step 6. One is the patient will have dialed it forward to a point where their jaw is comfortable and their airway is under control. Their symptoms, their bruxing, their TMD issues, whatever it is now gone. You tell them, all right, that's great, let's wait another 7 days and see how you're doing. At the end of the 7 days, if everything is still doing well, rescreen them. If the positive subjective and objective reports are made, then go to your doctor and say, I think the patient is better at step 6 with this amount of protrusion. So what are you going to fabricate? Your dentist will tell you to fabricate a style of oral appliance at this time. It can be an orthodontic appliance, or it could even be a sleep appliance. Remember, if it happens to be a sleep type of appliance, you need a sleep study and a letter from a physician of the medical necessity of that particular appliance. What do you use for the bite registration? Because you're going to send cast to the upper, cast to the lower, and normally we would just make a haphazard bite at a protrusion that we thought was appropriate. You don't have to do that anymore. Just give the laboratory a locked down version of the MyTap and say, make it exactly in that position. That's where the patient is actually having their most success. So the MyTap gives you the ability to create the final sleep appliance at the exact dimension that's been working for the patient. Now, once you get that appliance in their mouth, you call it the control appliance, but it's always important to try to get rid of the appliance. You're under control. How can I take it away? By the time you've reached this point, the surgeries, the anatomic changes, and all the intervention strategies are going to be interdisciplinary in nature, and they're going to be larger types of interventions. More than likely, you're thinking some form of orthognathic component to this in order to make the skeletal anatomy more normal. Weight loss, myofunctional therapy, otorhinolaryngology, and orthognathic procedures all need to blend together to provide the optimum solution for this particular patient. Now, the other answer is, I've dialed this thing as far forward as I possibly can, and I'm not getting resolution. If that's the answer, remember, always celebrate the fact that you didn't make them a final device. You didn't charge them a huge fee for a sleep appliance, which is what we would have typically done, and found failure after a huge investment. Tell them it's so much better that we figured it out this way, with a protocol that walked them through to find that out. Now you have to determine what would be the next course of action. Who would be the next person in line to try to assist this patient in figuring out how to make their airway better?